Hello everyone. Today we will be looking at and talking about how you are going to approach a patient who comes to your emergency department. So, what is an emergency? An emergency is nothing but any situation in life that requires immediate attention, reception, assessment, identification of the emergency, necessary interventions, supportive care, special care, and or initial resuscitation. Now remember, whenever a patient comes to the emergency medicine department, you are supposed to look at the patient and not at the gadgets which are surrounding you and the patient in the ED department. Why is that? If you look at this particular slide, you will find that this is a single patient who is monitored by two different gadgets, by two different pulse oximeter, one a finger pulse oximeter and another one which is used in the ICUs for monitoring. And you find this patient who had come to the department with acute onset of breathlessness, severely ill in respiratory distress. One of the pulse oximeters was showing a saturation of 97, which is normal, and the other pulse oximeter, the standard pulse oximeter, was showing a saturation of 90 and the pulse rate was 124. That means these are two different equipments, but for the same purpose, showing two different values, and you and I know that this particular hand pulse oximeter or finger pulse oximeter is showing an erroneous value, supranormal value. This patient cannot have a saturation of 97 because this particular patient was severely in respiratory distress, and the subsequent arterial blood gas analysis also proved the patient was in hypoxia. So, now what are the emergency situations which can occur in your life or the ED? In a hospital, a patient who is being treated for some routine illness in the ward or in the room can go in for a catastrophe. A patient who is consulting you in the OP can undergo an acute illness right in front of you. This emergency can occur in the ICU where already patients are ill. This emergency can also occur in the operation theatre. It can occur in the casualty, or an apparently normal person who is doing his routine jobs outside develops an acute cardiac or respiratory or neurological illness which leads to an emergency situation, which is called a pre-hospital or out-of-hospital emergency catastrophe. So, these are the situations that we are likely to come across in our life. Now, examples of any illness which may become severe is, for example, a chest pain. A chest pain could be due to even a herpes zoster occurring over your chest, which can lead to excruciating pain, and it is not a medical emergency. Whereas a chest pain occurring over the left side, constricting chest pain over the chest, radiating to the left arm, to the chin, is likely to be an angina pectoris or an unstable angina, which is the cause, or which is caused by a coronary artery disease, and it can lead on to maybe myocardial infarction and cardiac arrest, etc. So, chest pain could also be due to a pleurisy. Now, without a chest pain, you can have breathlessness due to so many reasons. The breathlessness can be of acute onset, it can be of subacute onset. An acute onset of breathlessness, one of the commonest things is the pneumothorax, an acute asthma, an acute pulmonary edema. There are several causes. Or wheeze. An acute wheeze could be due to again an asthma or even a acute anaphylaxis or even foreign body aspiration, which may look like a wheeze. Headache. Headache may be a simple headache. It could be due to hypertension. It could be due to a rupture of intracranial aneurysm. It could be due to hypertension, hypertensive crisis leading on to headache. There are so many things. An IVDP can lead on to a backache. It could be of acute excruciating pain. An abdominal pain. It could be a simple abdominal pain like a gastritis. It could be even a peritonitis. It could be a pancreatitis. There are so many reasons. It could be a perforation. Could be an acute appendicitis. perinephric abscess coming with abdominal pain, back pain. Convulsions. Convulsions, when we hear of convulsions, we will think of epilepsy and things like that. But remember, febrile convulsions, dysalkyltemia causing convulsions, hypoglycemia causing convulsions, hypercarbia causing convulsions, hypoxia causing convulsions is also to be added in the list of causative factors of generalized clonic tonic seizures. So, the seizure may be due to so many electrolyte imbalances also. A fall and a fracture, a head injury or a injury to the long bones like a femoral fracture, fracture to the ribs causing a flail chest, causing a hemothorax, causing a pneumothorax. These are all causes especially occurring in a road traffic accident. Fever, yes, a high grade fever in malaria can lead on to, for example, cerebral malaria can lead on to convulsions, hypoglycemia, dysuria, bleeding, stab injury, gunshot injury, loss of consciousness due to several causes other than intracranial pathologies, dislocations, foreign body aspiration into the lungs, electrocution, drowning, chemical exposure, the list is endless. So, you are likely to face with any of these situations while you are in the emergency medicine department. Now, when they come to the emergency medicine department, the first thing we have to do is what is called as triaging. So, there are color coded triages, there are several triagings available. So, when a patient comes with an acute crisis and needs our immediate attention, that is categorized in the red zone, which is the patient has to be administered drugs or necessary care at the earliest as an emergency. And it is urgent, but if it's very urgent, it comes in the yellow section, and it requires only a standard routine care, it comes in the green sections, and it is a non-urgent, it comes in the blue section. So, when you come to the ED department, you can see the color coded areas. We have different sets of codes which are available for the red, the yellow and the green patients. So, what is actually triage? Triage, the terminology means targeting, relativity, intervals, analytics, grouping and explore. This is actually the word meaning of triage. Now, what are the 7 steps in emergency? This is a simplified form of how you are to approach a patient who comes to the emergency department. 1, a patient comes, either a walk-in patient or a patient who is in the trolley or a patient who is in a wheelchair or an unconscious patient. The patient could be conscious or unconscious, or the patient could be also be brought in a state of cardiac arrest. So, first thing is receiving the patient. Once the patient or the bystander wheels in the patient, immediately you are supposed to stand up, go see and look at the patient and do the initial assessment and identification. Immediately identify what type of patient it is. Does it require immediate attention? Then you have to triage the patient into the red, yellow or the green category. And assessment, once you categorize, you have to assess. So, how do you do the assessment? Assessment is always by checking the vitals, that is the most important thing. And when the BP is low or the patient is in arrest or respiratory distress, you have to put in, immediately start what is called as a lifeline. While doing the vitals assessment, you are mandatorily required to put in an IV line, so that you have something to instill fluids or blood or drugs or whatever that is. So, you have to have what is called as an immediate line, IV line, that is called as the lifeline for necessary interventions, which may be drugs, antibiotics, fluids, adrenaline, so many things. And then if the patient needs a supportive care, for example, instilling fluids, the patient is hypovolemic, the patient has vomited, patient is in diarrhea, and you find that the patient is hypovolemic, the BP is low, you have to give supportive care, you have to start IV fluids, try to bring up the BP. Then the patient is a bronchospasm, you have to give nebulizer, steroids or whatever that is necessary. So, you give necessary treatment, whatever you find to relieve the symptoms of the patients in the first hand. And then, for example, the patient, let's say the patient has got a chest pain and you identify that it could be a coronary artery disease. The ECG shows changes like an ST elevation, T inversion is there, features of an anterior wall MI or a inferior wall MI, and you know that this particular patient requires an intervention in the form of a primary angioplasty, and then you'll have to contact the cardiology department, shift the patient at the earliest if the ICU is free, and give special care to this particular patient. This is only example I am saying, not saying that every patient who comes to the ED department will have a coronary artery disease. I am just saying about special care. Special care does not come in the cardiology department alone, it comes in the pulmonology department, the neurosurgery department, the neurology department, gastroenterology department, ortho department, surgical department. Every department will need special care pertaining to their field of interest and pertaining to as the patient requiring that specialty care. And of course, any patient coming with a medical or a surgical problem can go in for the most devastating case of a cardiac arrest. Cardiac arrest may not necessarily be due to a cardiac problem, it could be due to a trauma, it could be due to poisoning, it can be due to arrhythmias, it could be due to so many factors. So, in that case, cardiac tamponade after a road traffic accident, so many things. So, in these cases, when the patient comes with an arrest, remember, even a foreign body, if it is not identified, foreign body aspiration into the main bronchus can present to you with cardiac arrest. A pneumothorax in the late stage, if it is not identified properly, may come to the ED department with features of cardiac arrest. And if you miss the primary diagnosis, you are going to miss the bus. So, when a patient comes with a cardiac arrest, you have to go in for the life support, basic life support, advanced cardiac life support. If it's a trauma, you have to go in for trauma care life support. Okay. So, then approach in ED, basically it is, all of you have heard about the A, B, C, D, E of approach to a patient in the emergency department. A means airway. You assess the airway, whether the airway is clear. So, whatever you do, supposing the patient is choking in his own aspirations, or a foreign body, or a blood aspirated in the airway, or due to trauma, the trachea is damaged, and then in that case, probably you have to maintain the airway. Whatever type of treatment you do, if you do not maintain the airway properly, you are likely to lose the patient. So, that is why airway, looking at the airway is the most important thing. The breathing pattern, the breathing, whether the patient is in respiratory distress, patient has got tachypnea, patient has got a bradypnea, or disordered breathing change. So, there are so many types of breathing, and you can assess whether the patient is in distress. And circulation, whether the peripheral circulation is normal, the central circulation is normal, whether the capillary filling is normal, whether the BP is normal, and the patient who has got a simple episode of vomiting can go in for a hypertension. Patient with got severe diarrheal disease can go in for hypertension. Patient with hemorrhage, either due to trauma or a hidden hemorrhage, for example, a retroperitoneal hematoma, or a hematoma developing after a fracture of the femur, long bone fracture, they can have a huge loss of blood, even up to 1 to 2 liters. You may not know it. Patient may go in for hypertension. Hypertension in sepsis. There are so many things. Cardiogenic shock causing hypertension. These things can cause decrease in circulation and hypertension. That has to be corrected. Disability. What are the disability assessment? Whether it is a surgical disability, orthopedic disability, neurological disability, whatever. What is the basic disability that you are going to assess? And exposure. So these are the. And once you have a patient, you do a primary survey. For example, this is especially important when you have a patient brought with trauma. You do a primary assessment just to see what is the Glasgow Coma Scale, the level of consciousness, etc., etc. And then once you finish the primary survey, you have to go in for a secondary survey to assess whether you have missed out on anything. For example, a patient coming with a trauma may have a head injury, which is the main important presenting feature, but you may miss out a fracture of the femur or a rib fracture if you are not very careful. So, in the primary and secondary survey, it is mandatory to see that you do not miss out any secondary illness which is lying hidden in that particular patient. So, and basically it is a teamwork in the emergency care. Basically it is a teamwork by a team of doctors, supportive medical care team, the staff nurses, the whole team has to work as a team. And the most important thing, whenever a patient who comes to you, if the patient is not in arrest, the most important things are to check the vitals. The pulse, you have to check all the pulses. The peripheral pulses are not palpable. You have to check for the femoral pulse or the carotid pulse on either side. Sometimes the dorsalis pedis may not be palpable, and it is ideal to check all the peripheral pulses, including the dorsalis pedis and both radials, so that you do not miss out. For example, if a patient has an peripheral arterial occlusive disease, you might miss it if you do not check the pulse. And then the checking of the blood pressure. Manometry blood pressure recording is very important, and it's ideal if you are seeing the patient for the first time. It's good that you check the blood pressure on both arms. Sometimes there might be a difference in the blood pressure in both arms, which is called as anisosphygmia. And sometimes, for example, in dissecting aneurysm of the aorta, there might be an absence of a pulse on one arm, on one side. So this is a clue that you are dealing with a chest pain, which is likely to be a dissecting aneurysm of the aorta. And then when the BP is palpable and when the pulse is full, when the patient is not in shock, you can use the finger pulse oximeter to check the saturation. But remember, saturation should be checked at least for 1 minute, 1 whole minute, so that the pulse oximeter, the finger pulse oximeter or the large monitor which also checks the pulse, the saturation, has enough time to standardize and give you the correct value. Remember, no two pulse oximeters are alike, which I have already shown you. So be careful when the patient is in a respiratory distress or dyspneic and cyanosis. If they show you a normal saturation, it is likely to be wrong. You can check with another pulse oximeter, finger pulse oximeter, or a standard monitor which also checks the pulse oximeter. And the respiratory rate, the patient might have bradypnea, irregular respiration, patient might be tachypneic, patient might be severely dyspneic, patient might be in acidotic breathing. For example, patient who has got type 2 respiratory failure, that means the carbon dioxide is high, is likely that they will have an acidotic type of breathing. And then temperature. Remember, any patient who comes to you first should always have a temperature recording as a part of your vitals, because the patient or the bystander might tell you there is no fever, but when you check, especially in elderly patients, you might not be able to appreciate fever with your hand or palm, but when you record with the thermometer, you will find to your surprise the temperature might be 102, 103, and you might have missed out febrile illness like a pneumonia, etc., if you do not check out the temperature. And there are also conditions where there is hypothermia, hyperthermia. There are so many conditions like that. And just for information, one of the most common things with which, other than trauma, with which a patient comes to the ED department is acute chest pain or with breathlessness, or breathlessness with or without acute chest pain. So we will just rush through, because this is a very important point for you to know that, remember, a patient at any age who comes to the ED department with acute onset of breathlessness with or without chest pain, on the left side or the right side, the first and foremost thing that you have to rule out is nothing but pneumothorax. Remember, at any age, a patient who comes with an acute onset of breathlessness, sudden onset, in a patient who does not have any predisposing factors or comorbid conditions, the first thing to rule out is pneumothorax, because pneumothorax is a medical emergency which also requires a mini surgical treatment. And if you miss out pneumothorax, you are going to miss the whole thing. So remember, pneumothorax, the patient becomes absolutely breathlessness and air entry is reduced, the chest movements are reduced on that particular site. There will be hyperresonance and absence of breathlessness on one side, and you diagnose that with an X-ray. If you have any doubt, you have to mandatorily go in for a CT thorax to rule out a pneumothorax if you are in doubt. The next thing is an acute pulmonary embolism. Acute pulmonary embolism can also occur at varying of ages. Childhood acute pulmonary embolism is a little rare, but above the age of 15, 18 years, pulmonary embolism is not an uncommon thing. That again presents with acute onset of breathlessness with or without chest pain, and there is likely to be a history of travel, a long distance travel in the bus or flight, or a history of taking oral contraceptives, or history of underlying some other disease. And then the patient presents with acute onset of breathlessness. You have tachycardia, tachypnea, and initially the oxygen levels might be normal, but then later the BP starts falling, the saturation starts falling, the patient goes in for a probably an arrest, and the patient collapses and dies if it is a massive embolism. So, and here clinically you do not find anything other than a tachypnea, tachycardia. Initial BP might be high, then the BP goes low, the saturation goes low, chest X-ray might appear normal, ECG might show only a sinus tachycardia. Your classic S1, Q3, T3 may not be seen in all cases, and in this case, of course, D-dimer will help you to rule out a pulmonary embolism, because negative D-dimer usually rules out an acute pulmonary embolism. The diagnosis is by D-dimer and a pulmonary angiography. Acute pulmonary edema due to left ventricular failure. This could be due to coronary artery disease, anterior wall myocardial infarction. This could also, an acute LVF could also be due to hypertensive crisis. Remember, hypertension can cause an acute pulmonary edema with a preserved ejection fraction. So, if you do an ultrasound and echocardiography and look at the LV ejection fraction, it may appear normal. You may not see a regional wall motion abnormality, and then you will be falsely misled to believe that this is nothing to do with the coronary. It is not pulmonary edema. You might think of some other things like a bronchiolitis, etc. No, that is not true, because pulmonary edema and left ventricular failure can also occur with a preserved ejection fraction. So, patients with CKD, chronic kidney disease, can go in for what is known as a flash pulmonary edema. Patients with hypertension can again go in for a flash pulmonary edema. Then another condition where a patient develops an acute onset breathlessness is simple asthma. A patient can develop asthma at any age, and it might be the first time it is precipitated and the patient presents to the ED department with an acute onset of breathlessness and audible wheeze. So, wheeze is an audible rhonchi, and the patient is visibly distressed, and initially the blood gases might show only respiratory alkalosis, and then initially the saturation might be normal, then it starts dropping. So, diagnosis is by clinical history, ruling out other causes, and clinical findings of bilateral rhonchi, which is said to be polyphonic. Polyphonic rhonchi is a classic sign of bronchospasm. So, with no history, and there is a history of exposure to some dust or a paint or some chemical exposure which leads on to onset of bronchospasm. So, this could be an onset of acute asthma. Anaphylaxis, drug-induced anaphylaxis. There are a lot of patients who come to us with food allergy and anaphylaxis. Drug anaphylaxis, there have been patients who have been taking penicillin for years and then goes in for a test dose and develops an anaphylaxis at the time of the test dose taken 13 years consecutively, and the 13th year they develop an anaphylaxis. Oral drugs taking, one of there are several drugs which can precipitate. Aspirin is one of them, ibuprofen is one of them. There are so many drugs which can, if the patient is allergic to, they can precipitate rash, and sometimes they can precipitate a laryngospasm. They also can precipitate a bronchospasm, especially in asthmatics, patients who take beta blockers or NSAIDs. An asthma can be precipitated, and they can go in for asthmatic attack along with an anaphylaxis. So, anaphylaxis, even a bee sting can cause anaphylaxis. Bee sting, scorpion bite can cause anaphylaxis. So, these are the things. Then comes acute MI. Acute MI, again, patients develop a breathlessness. They usually have a constricting chest pain and chest tightness, and sometimes if they are diabetic, they may not have a chest pain. They might have only chest constriction, they might have dyspepsia, feelings of gastritis, belching, and they may miss the diagnosis of acute MI. And of course, ECG might show changes. The tropi might be elevated if you are doing it after 4 hours. And if it has got developed regional wall motion abnormality, probably you might be able to pick it up by using ultrasound, bedside ultrasound. Children, even adults, can present with foreign body aspiration, and this becomes acutely ill when it is aspirated. It's a large foreign body aspirated into the trachea or the main bronchus. So, the classic sign of the hand touching the throat and doing that, the patient is unable to speak, and patient points with his hand. This is the universal sign of choking, a foreign body in your trachea or the main bronchus, and the patient is unable to speak, and you will have to resort to the Heimlich maneuver to see whether you can extrude the foreign body which is stuck. If not possible, you might have to go in for an emergency rigid bronchoscopy, etc. Cardiac tamponade, this can occur in a patient who is taking anticoagulants like warfarin, rivaroxaban, apixaban, and so many anticoagulants. Secondary to trauma, secondary to patients who are having lymphoma, they sometimes present with cardiac tamponade. Patients with trauma also can have cardiac tamponade. and the patient's blood pressure will be low, the jugular venous pressure will be elevated, it might be non-pulsatile, and when you put in an IV line, one of the classic signs of identifying cardiac tamponade is when you put in an IV line and the blood spurts out of the vein. So, when the venous pressure is very high with an elevated JVP and the X-ray shows a huge cardiomegaly or a water bag sign, it is likely to be a cardiac tamponade. So, remember, when you put in an IV line, the blood spurts out from the vein. If you put your needle into the vein, it is likely that there could be a high pressure outside the heart, which is likely to be a cardiac tamponade. And again, diagnosis is by an echocardiography. Traumatic effusion hemothorax, hemopneumothorax. This can occur when a patient has a fall or a road traffic accident, and when any patient who is brought in with a history of fall from a tree or a road traffic accident, remember it is mandatory to rule out hemothorax, pneumothorax, or a combination of both like hemopneumothorax. And it will be ideal to get a chest X-ray, and if you are in suspicion, to necessarily go in for a CT thorax to rule out any undetected fractures of the rib or a pneumothorax or a hemothorax. Acute respiratory failure due to pneumonia or ARDS, a patient developing a large pneumonia, a viral pneumonia, or even a lobar pneumonia due to pneumococci or Klebsiella, they can develop acute or a subacute development of breathlessness, hypoxia, and they can go in for a dyspnea and respiratory failure. ARDS is a condition which is related to pneumonia, but remember, ARDS is nothing but acute respiratory distress syndrome, which presents even in a patient who does not have any prior respiratory lung pathology. This is an inflammatory pulmonary edema. There is a leak into the pulmonary alveoli, secondary to even blood transfusion, a shock, sepsis, even a ruptured appendix. There are fat embolism. There are so many conditions. Even a pneumonia also can lead on to ARDS later. So, remember, for ARDS, when the primary ARDS, the pathology is in the lung, the secondary ARDS, the pathology is elsewhere in the body. It could be a sepsis anywhere in the body, which can lead on to a non-cardiogenic pulmonary edema. The other name for ARDS is non-cardiogenic pulmonary edema, and the treatment is necessarily by the diagnosis by arterial blood gas, and the treatment is basically by intubating and ventilating the patient. So, this can also present with acute respiratory failure. It is a respiratory failure which is resistant to treatment with oxygen or even non-invasive ventilator. So, resistant refractory hypoxemia, that is the classical triad of ARDS. And a snake bite or a poisoning can go on to leading a skeletal muscle or a neuromuscular failure, which can again lead on to respiratory paralysis. Polio is one condition which can cause respiratory paralysis. Snake bite, Guillain-Barré syndrome. These are conditions which can lead on to respiratory failure. Myasthenia, myasthenic crisis again can present with acute onset of dyspnea, myasthenic crisis. So, these are some of the conditions which you should keep in mind, so that you do not miss these conditions, because the treatment of each is entirely different. For example, pneumothorax, there is no point in giving oxygen, you have to put in an intercostal tube. For myasthenia, you have to treat with drugs. With acute LVF, you have to treat with the diuretics, oxygen, etc. So, the treatment is entirely different, foreign body, but all these conditions causes acute onset of dyspnea. So, this is the main thing. So, you have to make a diagnosis important in these things. So, well, this is a simple classification of the types of patients that you see in the emergency department. One is not a patient who is brought in cardiac arrest or a broad death patient, or the group C is a patient who is brought in cardiac arrest and you do for resuscitation. Group B patient is any patient who is not conscious or impaired or altered consciousness comes under group B, and all the other patients who are conscious, whether they are bedridden, coming in the wheelchair, but if they are conscious and oriented, whether they are acutely dyspneic or not, comes under category A. So, this is a simple classification, because the management will be entirely different in these 4 categories. Now, coming to the last of the session, what are the things that you require in your emergency teamwork? So, there is a long list, and the list is becoming more and more longer as the days passes by, because the emergency medicine department is growing and the procedures that are being done are also increasing. Stabilization clause and also we give treatment. For example, thrombolysis for both pulmonary embolism as well as acute myocardial infarction is, or a thrombolysis for a cerebrovascular accident like a clot in the brain. That is nowadays being routinely done in most of the emergency medicine departments. So IV line, fluids, airway, suction, needles, syringes, oxygen, oximeters, manometers, monitors, ambu bag, defibrillators, mini track, all the emergency drugs, the ECG machine, the portable X-ray, the ultrasound, ultrasonography, or what is called as the POCUS, point of care ultrasound, a non-invasive ventilator, and the invasive adult or the pediatric ventilator. So these are some of the lists of equipment which are available, which should be available in any emergency department. And that, for concluding, is how you look at the Glasgow Coma Scale whenever a patient who comes to you who is not having an altered sensorium. This is the way you look at and assess the Glasgow Coma Scale by scoring E, M, and V. E is up to 4, M is up to 6, and V is up to 5. So E stands for visual response, M stands for motor response, and V stands for verbal response. So when you say the Glasgow Coma Scale is 3, that means the patient has got a very poor chance of recovery. And when the next day when you see the patient is Glasgow Coma Scale of 5, that means there is some improvement. So the maximum Glasgow Coma Scale is, as you can see, is 15. That is the maximum. So when you say a score, you say Glasgow Coma Scale is 5 by 15. That is how. So it's a very important parameter for assessing. And coming to the end, this is in a nutshell how you look at a management of an acutely ill patient who come to the department. The patient has got, the first thing is to make sure that the patient has got a history of trauma or not, or there is no history of trauma. Check the vitals, look at the breathing, look at the airway, look at the pulse, the BP saturation temperatures, assess the level of consciousness, put in the Glasgow Coma Scale, awake, unconscious, or in arrest. The patient is in cardiac arrest, go in for immediate resuscitation of the patient, ACLS, ATLS, and then expert care. And the patient is awake, get a detail. The patient is awake and conscious and comprehending. It is mandatory you get a detailed history of the patient regarding the illness as well as the drug history. There are so many times when the patient will forget to tell you about the drugs that he or she has been taken, and so you might have a drug interaction, and this particular illness with which the patient has come to the ED department could be a result of some of the drugs which he or she has taken, either due to a drug reaction or unnecessarily consuming more and more drugs. So the drug could be the culprit in that particular case. So it's very important to look at all the drugs that he or she has been taken if the patient has got a prior history of any other illness. And then look for or ask for pain, breathlessness, giddiness, drug anaphylaxis, etc. And then you go for assessment of all the routine blood parameters, starting with blood sugar, because hypoglycemia is something which can mimic a lot of things, including convulsions, including respiratory failure, including tremors, including altered sensorium. So hypoglycemia can even present as a hemiplegia. So remember, whenever a patient comes to the ED department with altered level of sensorium, mandatory that you start off while checking the vitals with measurement of the blood sugars. Always rule out hypoglycemia, hypoxia, hyponatremia. That's why you look for the blood RBS electrolytes, signs of stroke, and your approach to rule out a stroke will be after completing the blood investigations like blood sugars, blood routine, sodium, potassium, magnesium, then the RFT. Sometimes uremia can present with acidosis and convulsions. LFT, sometimes you might miss out a hepatic encephalopathy if you do not check the bilirubin and the SGOT, SGPT. So you might miss, in dim light you might miss out the jaundice. So remember to do the blood routine, the electrolytes, the RFT and the LFT, and once all these things are normal, and you will have to also rule out poisoning, a snake bite or a poisoning, even a homicidal poisoning or inadvertent suicidal poisoning. All these things has to be ruled out, and all these things are not there. You have to go in for look for stroke signs, alcohol intake, and then try to assess the patient. So, that is in nutshell. So, the chain of survival, all of you know, BLS and ACLS. So, this class, the purview of this class is limited to how you approach a patient to BLS. And so, I hope I have had the opportunity to get some vital points and vital clues as to how to approach a patient who comes to the emergency department. Thank you. Now, if you have any questions, I will be glad to answer them.